welcome to the Type 2 Inflammation Connection in Chronic Sinusitis with Nasal Polyposis, optimizing our patients' identification and targeted treatments. This is the second in our two-part series navigating treatment in Type 2 inflammation-driven chronic sinusitis with nasal polyposis, practicalities, and a team-based approaches for selecting biologic therapies. I'm Christine Franzese from the University of Missouri, and joining me today is Flavia Hoyte from National Jewish Health.
Thank you. So happy to join you tonight.
Thank you to PeerView for providing the session and to Regeneron Pharmaceuticals and Sanofi for providing the educational grant for this symposium. Reminder, please look out for additional polling during this presentation and feel free to submit your questions as we will answer them during the Q&A session. Please also visit us at peerview.com, T2 in CRS with MP. The slides and the practice aids can be accessed in the activity menu now and downloaded after the session. The goals for today are that during this presentation, we will learn that incorporating biologic therapies into the treatment of patients with chronic sinusitis with nasal polyposis should be guided by the latest evidence, the inflammatory endotype of the patient, and the presence of type 2 inflammatory comorbidities. A shared decision-making approach to chronic sinusitis with nasal polyposis management includes patient counseling, monitoring, and anticipating treatment results and timelines. So, to get started, let's talk about the practicalities of choosing the different biologic therapies in our patients with nasal polyps. One of the things that we are very fortunate to have is, in addition to surgery and steroids, we now have multiple treatment options. So, a number of these monoclonal antibodies are now available. On this particular slide, you'll see the first three that were approved for treatment. These are a summary of the three phase 3 trials for dupilumab, omalizumab, and mepolizumab. You'll see on the top of the slide the nasal polyp scores. These are the least squared mean changes, and the nasal congestion scores are along the bottom. Now, there are a little bit of differences between the treatment populations. So, for example, in the MEPO trial, every patient was required to have had surgery. And not just that, they had to have surgery within the last 10 years, which is really important because our surgical techniques have changed. But all of these patients were adults. They all had run ins with nasal steroids. And you'll notice that all of them are FDA approved. The two primary endpoints were the polyp score change as well as the nasal congestion score at the end of 52 weeks. The first one, dupilumab, you'll see a score of about 2 in that. With omalizumab, there was a change in the score of about 1. I know the graph is a little bit deceiving. It looks like they're the same, but it's just a different scale. And then mepolizumab, this is more a breakdown of the number of different patients that have different points improvement in their scores. Overall, the gestalt to this is sort of also what I experience with MEPO in my practice is roughly 50% of the patients improved by at least 1 point or more, but about 50% of them stayed the same or got worse. When we look at the nasal congestion score changes, though, again, there's a little bit of differences in the scoring system. The MEPO scoring system was a visual analog scale from 0 to 10. The other two studies involved a scoring system from 0 to 3. But overall, you can see that patients' symptoms improved pretty early on in the treatment and continued in that improvement throughout the course of the trial. Now we have tezepelumab. That's the newest player on the market. Recently got approval through its phase 3 Waypoint trial. Again, similar to the other trials, the two main endpoints were change in nasal polyp score, as well as change in mean congestion score, with the polyp score to your left there and the nasal congestion score on the right. And again, this was a year study. Now, similar to the dupilumab and omalizumab studies, patients were not required to have surgery, but they could have had surgery or at least exposures to systemic corticosteroids or some contraindication that they could not have either steroids or surgery. And you'll see similar actually to the dupilumab results, there's a change of about a decrease of 2 in the nasal polyp score, as well as improvement pretty early on in the nasal congestion score that is maintained throughout the trial. Interestingly, this is something we don't see very often, which is a head to head trial. So, this was recently reported the results of Everest, which was a phase 4 trial comparing dupilumab to omalizumab in patients that had both severe chronic sinusitis with nasal polyposis as well as severe asthma. On the top, you'll see the nasal polyp score. To the side, you'll see the change in the upset score. There's a loss of sense of smell score, which is more of a visual analog scale. And then you'll see the SNOT 22, which is the quality of life measure that goes from 0 to 110. And the takeaway from each of these trials, from each of these graphs is with this first head to head trial, now granted, this is really in patients who had severe nasal polyps as well as asthma, but strong two type inflammatory conditions, that everybody had improvement, but you'll notice that across the board, there really is statistically significant improvement in nasal polyp score, improvement in sense of smell, as well as quality of life measures that were greater in the dupilumab group compared to the omalizumab group. So before we move on, please take a moment to answer a follow-up poll on findings from the Everest trial. We have some other emerging therapies. Again, this is very, very exciting. So, depemokimab, this is an ultra long lasting anti IL-5 agent. So, really only 2 injections a year. The phase 3 trials are Anchor 1 and Anchor 2, and they showed statistically significant improvement in the co primary endpoints of nasal polyp score, as well as mean nasal obstruction on a verbal response scale versus placebo in patients with CRS with MP, and it was generally well tolerated. Stebokibart is another anti-IL-4, IL-13, a monoclonal antibody. Now, its phase 3 trial was called Crowns. And among patients with severe CRS with MP, which were treated with daily intranasal corticosteroids, it reduced polyp size and severity of nasal symptoms at 24 weeks. There were some serious AEs, but they were very rare. They tended to have higher rates of arthralgia as well as hyperuricemia that were reported in the treatment group as opposed to the placebo group, respectively. One of the things our patients will want to know is, well, which should I use, doctor? What do you think is right for me? And that can be a very complex question for our patients, and there's a lot of factors that interplay. But I feel this graph that is taking indirect comparisons from the different trials. Now, again, we have some caveats looking at this graph that there were some differences in the populations enrolled in these trials. So, for example, all of the MEPO patients in the Synapse trial had to have prior surgery, and it had to have surgery within at least 10 years. And that had to be surgery that removed tissue. So they're a little bit different. But overall, as a whole, these types of indirect comparisons for the different biologics can be a helpful guide in giving us an idea of when we talk to our patients, what potentially we may choose. So you'll notice that looking at the differences in nasal polyp scores, again, there's a little bit of difference in the populations that were enrolled, but we can see that overall dupilumab and tezepelumab were very similar in the changes in nasal polyp scores. And then it's followed by omalizumab, and then it's brought up by depemokimab, benralizumab, and mepolizumab, so the IL-5. So this kind of gives us a nice gestalt of what we might be looking for in change in nasal polyp size. But honestly, I'll say for me, even as a surgeon, size doesn't matter as much as our patient's symptoms because even if the polyps shrink, if our patients are still miserable, then we really haven't done a whole lot of benefit. So here's another graph that kind of breaks down. Again, this is an indirect comparison, but it gives us an idea of the different changes in nasal congestion scores. Now, again, there were some differences between the different scoring systems, particularly with MEPO, which was 0 to 10. But at least this is a way where we might quickly get an idea of the potential benefits we might have in improvement in nasal congestions, where we see again the way is kind of led with tezepelumab and dupilumab, followed by omalizumab, and then the IL-5 inhibitors. Looking at change in sense of smell, whether we're looking at the overall Gestalt loss of sense of smell score, which again tends to be a rating scale either between 0 to 3 or 0 to 10, or the UPSIT, which is a scratch and sniff booklet of 40 items. And that does vary between gender and age. But again, we get an idea of improvement of sense of smell because that's one of the things my patients will ask very commonly is, what's the chance that my sense of smell will come back? And looking at this, you can see again with this indirect comparison that tezepelumab and dupilumab tend to be more effective in improving a patient's sense of smell than the IL-5 as well as the anti-IgE inhibitors. So here's another graph, again, looking at the 4 FDA-approved options we have for our patients: dupilumab, omalizumab, mepolizumab, and tezepelumab. And I do want to call out that you'll notice that 2 of them are available for adolescents. So dupilumab and tezepelumab are for 12 and up, whereas the other 2 are for adults only. And you'll also notice that, I mean, these target type 2 inflammatory cytokines that they tend to be also approved for other type 2 inflammatory conditions. So, can biologics and surgery be used together? And do you have to have surgery? Well, most of the clinical trials, excluding the Synapse trial with MEPO, there were patients that were enrolled that did not have surgery. Now, there were patients enrolled that did have surgery. Those tend to be the majority of patients, but there were surgery naive patients. And particularly in post hoc analyses that were done, looking at several of these studies, efficacy was found in both of these groups, whether or not you had surgery. So, potentially, if there is a contraindication to surgery, because let's face it, there are some patients that are too sick for surgery, there are some patients that can't stop certain medications that we would like them to stop for surgery. So, surgery isn't necessarily right for everybody, and it doesn't necessarily have to be a prerequisite. However, surgery is a great option for many patients, and a lot of us have discussed, where do biologics fit in the timing of surgery? Do we use them before surgery? Do we use them after surgery? Well, before surgery, what we're doing is looking to reduce inflammation and polyp size, potentially making surgery easier, safer, faster. And also, we've discussed that there are long term consequences to oral corticosteroid use or systemic corticosteroid use. And it is not uncommon still in practice that prior to surgery or immediately after surgery, we may give the patient a burst of steroids. Could we potentially avoid that by initiating a monoclonal antibody prior to surgery? Or do we wait till after surgery and see if the patients recur? From the DeConda study in 2017, we know that 60% of patients don't recur, and they don't recur quickly. And so maybe we need to do surgery and wait and see what happens. And if patients recur or they have tissue with eosinophilia or other markers that seem to suggest they may recur very quickly, maybe we need to initiate it more quickly after surgery. So there's a lot of debate as to like when do we start these particular targeted medications. This is one particular study that's very interesting, looking at the changing part of this dynamic. This is looking at a prospective randomized placebo-controlled double-blind trial of 30 patients where all of the patients got targeted functional endoscopic sinus surgery, but half of them got about 14 weeks of dupilumab with injections starting about a month before surgery. So they got 2 doses prior to surgery versus the placebo that occurred during those 14 weeks. And then a follow up afterwards for 1 year. This is a little busy, but I want to point out the nasal polyp scores as well as the edema scores. And overall, the gist of this is both groups did very well, whether or not they had dupilumab prior to surgery and then for a few weeks after versus just the placebo. The results were very similar, but the key things to point out with this are it did seem like surgery was actually easier and safer in the dupilumab group, and that particular group actually maintained their sense of smell, had improved smell scores at a year as compared to the placebo group. So there's some interesting things that we can look at these perioperative use of monoclonal antibodies. So this brings us to our case, Joan. So she's a patient of mine. She's a 70-year-old woman who's had a diagnosis of chronic sinusitis with nasal polyposis, asthma, and aspirin sensitivity for quite a long time. She does have a history of allergies. She's had positive allergy testing in the past, and she's been on shots for 40 years. She's had sinus surgery 3 times, each 10 years apart. The most recent surgery she had was in 2013. She's on several different medications for which she's compliant with, including budesonide sinus rinses, which she's very religious with. However, despite this, she complains of loss of sense of smell, discolored nasal drainage, and nasal obstruction. That's been going on, but getting worse for the last 2 years. And despite all this compliance with all these medications, she still had 3 rounds of prednisone, 40 milligrams a day for at least 7 days, purely for her nasal polyp symptoms. She's otherwise healthy and she's never been a smoker. She did try aspirin desensitization, but she had to stop because of a GI bleed. Her IgE is not elevated. Her eosinophils are somewhat elevated at 620. Overall, though, her asthma is relatively well controlled, with her FEV1 beating 82% of predicted. Her SNOT 22 score, though, is in the severe range. Again, reminder, this is from 0 to 110, with 50 being in the severe range. Now, she hasn't had a recent sinus CT scan, and she's not interested in me getting one because she tends to associate getting a CAT scan with surgery, and she's really not necessarily interested in surgery. So she does elect to begin a monoclonal antibody therapy, and we did select dupilumab and started it at 300 milligrams every 2 weeks. And I wanted to show these nasal endoscopy pictures because this is something that doesn't always come across when we talk about our AERD patients. But as a surgeon, we'll note that not only are these inflammatory endotypes like AERD, allergic fungal sinusitis, chronic sinusitis with nasal polyposis, not otherwise specified, or central compartment atopic disease, these aren't just initials, but they can have real consequences for surgery and polyps. So you'll notice on this right nasal endoscopy where we see a picture of her nasal cavity and we see these polyps that these ones look to me more like the cocktail onions than the peeled grapes, but you'll notice that there's some bleeding. This was really just for me gently debriding some crusting that you'll see on the left side. And even with just that gentle debridement, she started to have some bleeding. And this reminds me that patients with AERD, they're more severe patients. Their surgery can be very difficult, it can be very bloody. The polyps tend to be different. And so this is something that when we have our multidisciplinary approach, when we come together with our allergy immunology colleagues, with our pulmonary colleagues, this is one of the things we discuss about. I mean, we do like to do surgery on patients, but sometimes surgery isn't the best option for our patients. So now I'm going to turn it over to Dr. Hoyt.
Thank you. That was wonderful. So I'm going to take it over from here and talk about team-based strategies for ensuring long-term treatment success with biologics. So you were just introduced to the data behind them and kind of thinking about which one we want to start. And when we go about starting, the communication is key. So we've mentioned this before, but communication in all directions. So talking with our colleagues, right? This chronic rhinosinusitis with nasal polyps is can, because of the comorbidities, really involve a lot of specialists. So ENT, pulmonary, allergy immunology, and then, of course, keeping the primary care provider in the loop in terms of all the different moving parts. Also, among different professions, so advanced practice professionals can be very important in terms of keeping patients uh, in line in terms of their treatment, their injections, and all of that stuff in between surgeries and in between appointments and that sort of thing. And then, most importantly, I think between clinician and patient. So that patient shared decision making, we've mentioned it a few times, but really discussing those goals of care, realistic expectations. So when are these medications going to take effect if we're starting a biologic? What kind of effect can you see from the surgery, and what kind of adverse effects can you see from either therapy or intervention, so that patients know what they're getting into, they can make that educated decision, and they can have hope. If it's too early to see a benefit, then they're not going to give up right away and get frustrated. They're just going to wait. And also discussing what their goals are. So depending on their goals, sometimes the interventions that we take as the first intervention is going to be slightly different. And so, in terms of engaging patients, I just mentioned some of this, but making sure to invite the patient to participate, empowering them. At the end of the day, you're the boss, but let me give you the options, right? So, presenting those options, providing information on benefits and risks. Patients really want to know this, and they don't want it to be sugar coated. They want to know what are my risks and what are the percentages. So, just to say that a percent of people have something is very different than knowing those numbers and being able to kind of give them context to how small or big a side effect might be. Assisting patients in evaluating options. So some patients, have done all the reading and they can kind of sift through the data and they tell you exactly what they want. And others kind of look to you for guidance. So, doc, tell me what works best and I'll do it. Or, you tell me if I should do surgery first or start a biologic. So in those patients who are asking for that assistance, you still make sure they know they're the boss, but kind of giving them the information they need. And then assisting with the implementation of, whatever decision is made. So, when talking about the different interventions, we obviously mentioned medication, surgery, the fact that they're not mutually exclusive, the fact that one or the other can impact comorbidities. A lot of patients don't realize necessarily that their comorbidities are related, and so sometimes educating them on that can be very helpful. Talking about which symptoms they might expect to improve, the fact that quality of life should improve, the importance of adherence, and of course, cost is a huge issue. And so we're always navigating that with insurance coverage and copay assistance, and all of that. And so, again, shared decision making, that's where it's at. Significant impact on patients' psychological well being, their adherence as well. If they're an active member in this decision, they're going to be much more likely to adhere to their therapy. And then, obviously, their confidence in their provider as well, because they feel like they're part of the team. We mentioned a little bit about managing expectations. So, in terms of biologics, just mentioning that initial improvement is not going to happen the next day necessarily, but in 2 to 4 weeks, you might notice some improvement, especially with regards to sense of smell and nasal congestion. Dr. Franzese showed those charts, and you could see those numbers started improving almost right away. But that the peak symptom control can take months. So, if patients start noticing some improvement, but it's not quite where they expected, make sure that they give it time. Gradual improvement's normal. And again, the response is variable from patient to patient. We talked about the different symptoms that can improve. Those patient reported objective measures like the SNOT-22 can be very important because it helps quantify the improvement, where a patient might say, I feel a little better, but not a ton. And having those SNOT-22 scores to say, like, wow, your score improved by 20, that's great. The minimal clinically important difference is 9, and so, or 8.9. And so having that objective measure can help bring context to the patient, like, look where you were struggling before, and it seems like you're struggling less in those domains. Give them hope that things could continue getting better. um, Biologics don't always help everybody, right? And so we want to continue reassessing in the clinic and making sure that patients, A, are tolerating, B, are able to afford the medication, and then C, of course, is it helping? And so if they're tolerating, if they're able to afford, then you probably want to give them a good 6 months on the therapy. Obviously, if there are severe side effects or anything like that, you'll switch earlier. But after the 6 months, if they're still not quite where they need to be, think about topical therapies. It could be that once they started the biologic, they stopped everything else. So sometimes we see that. And it might be that you need both, right? So getting them back on their intranasal steroid and rinses, addressing those comorbidities. So again, if they're not controlled, then the CRS may not be controlled. If all of that has checked out, then maybe it's time to switch biologics. And as Dr. Franzese mentioned, we've got a lot of options, especially for our adult patients. So not being afraid to switch. Sometimes patients are afraid to switch, but then just reminding them that this is not a final decision. If the first one ended up working better than the second one, we just switch back. And so sometimes that gives them the confidence to say, okay, I'll try something new, and maybe it'll be better. And if not, I have that option to go back. And then again, that multidisciplinary care, so surgery, may be needed in some patients who kind of deferred that extra surgery in order to try the biologic. But if it's not quite cutting it, then maybe it's time to go back to the OR. And then we talked about setting these realistic goals, about kind of where does the biologic fit in, what does it have the power to do, but then also maybe what sometimes it doesn't do. So before we move on, please take a moment to answer a follow-up poll on counseling patients with CRS with nasal polyps on biologic therapy. So, in terms of defining response to biologic therapy, the five criteria we think about are going to be the nasal polyp size. So, we need endoscopy for that. Systemic oral corticosteroids. So, again, that's a main goal of ours to reduce the need, improving quality of life, improving sense of smell, and then reducing the impact of comorbidities. So, if four or five of these improve, then we've got a good to excellent response. If one to three improve, it's a poor to moderate response. And obviously, if none of them improve, then we've got no response. And so after 6 months, we're going to evaluate the treatment. If we talked about kind of reevaluating, and if we kind of can make some tweaks, then we can leave them on and evaluate treatment again after a year. But if at any point it seems like we've kind of done everything we can with the biologic and in conjunction with the topical therapy, then it might be time to discontinue that therapy and kind of go back to the drawing board and figure out, is it time to switch to a different biologic, or time to maybe think about surgery. For our partial responders and our complete non-responders, again, the evaluation is going to be about some improvement or no improvement, and the strategy is going to be again, either continuing the therapy and monitoring, but considering a dose taper if they're stable. But then, of course, if there's no response at all, switching the biologic or thinking about surgery. And so, kind of on that note of possibly extending the dose or tapering therapy, this is a study surveying the ARD registry at Brigham Women's Hospital. So again, these are our most severe CRS patients in general, and the dosing interval for these patients. So they were try patients would try on their own to kind of space out from the typical every 2 week dosing of dupilumab to every 3 weeks, every 4 weeks, or even some patients went every 4 to 8 weeks. And you can see in the pie chart, many patients ended up going back to the every 2 weeks, about 25%. And then 6% actually ended up needing it more often than every 2 weeks. But the vast majority of patients were actually able to wean to every 3 to 8 weeks. And so that's just important. I mean, these patients love their biologics once they're working. They never want you to take it away. But after a certain while, they start kind of talking about, maybe we could space it out a little. And I'm all for that as long as control is maintained. So, about one third of patients in this study did try it and were able to, stay on a dose that was greater than every 2 weeks. And most common successful dosing frequency was every 3 weeks. So, let me show you results from another study here looking at tapering dupilumab. So you can see in the very light color is going to be every 2 week dosing. And then as it gets darker, patients are spacing it out further and further. So the light teal is every 4 weeks, and then the darker, the green is every 6 weeks. The forest green is every 8 weeks, and then the really dark green is every 12 weeks. So imagine a patient is able to actually use it every 3 months. And you can see more and more patients over the course of 96 weeks were able to space out their dose. And there was still a very small percentage at the end that had to stay on that every 2 weeks, but most patients were able to wean. And despite weaning the dose, you can see in the other two tables on the right that their control actually was better. So patients who were uncontrolled is kind of that darkest purple, and that amount decreased almost immediately at the 4 week mark, and then even further at the 12 week mark, and then really maintained quite low the rest of the time, despite the fact that many of them were weaning their therapy. Similarly, with the Euphoria 2023 response evaluation, right away there was a decrease, and then again it was maintained despite the dosing being tapered. Similarly, the sniffing stick, so there the score went up, which is good, and then was maintained despite the dosing tapering. SNOT-22 score, same thing, score went down, which is good, was maintained. And then the nasal polyp score as well went down almost immediately and was maintained despite tapering of therapy. Another question is about, is there any sort of disease modification where maybe we could stop the medication altogether and then continue with clinical benefit? And so this is a study looking at Synapse, which was the pivotal mepolizumab trial, but kind of a post hoc analysis thinking about the patients in the follow-up period. Are they also continuing to have improvement? And so even though their bloody eosinophils returned to baseline by the 76-week mark, and they had stopped the mepolizumab at 52 weeks, most of them continued to have improvement in terms of symptoms. So important to think about, and we don't know obviously long-term beyond that 76 weeks, but just an important thing to kind of keep in mind. So back to our patient, we have Joan who comes back. Now she's been on dupilumab for 9 months, and she notes a great improvement in her nasal congestion and restoration of sense of smell. Her asthma continues to be well controlled, but now she even needs her rescue inhaler even less. Her SNOT 22 score, if you remember, was 55 in that poorly controlled group, and now she's 18. So huge difference in her SNOT 22 score. And so together, Joan and we decide to taper her therapy. So every 3 weeks and see how she does. Of course, we mentioned that if things get worse at any time, just go back to the every 2 weeks, give us a call, but let's see how every 3 weeks go. And so 6 months later, she comes back and everything is just as good. So despite weaning, nasal congestion, sense of smell have remained the same, and they haven't worsened with that tapered dose. So a real success story. And then again, being able to taper is even better. And potentially the next step would be to taper even further. And then looking at her nasal endoscopy, I'm going to turn it over to Dr. Franzese, who's the expert. But even a non expert like myself can see that there's a huge difference there.
Yeah, and so she was someone we would call a super responder. Certainly, this isn't your typical or average response, but one of the things to point out is so we're looking at her nasal cavity. We have the left side, we have the right side. And one of the things surgeons will debate too is have they had good, adequate surgery? And her anatomy has been very surgically altered. And you'll notice there's some very large holes there. That is what we call large hole surgery. So you'll see that particularly on the left side, you can even see where part of her septum has been drilled away, where you can actually look directly into her frontal sinus. That's called a lothrop. She's also had very large megaantrostomies, and you can actually see directly into her sphenoid sinus all the way on that left side as well as the right side. But she's had such a great response. You can see very few polyps. She was very happy, but she had good sinus surgery, and despite the fact that she had good sinus surgery, she still had polyps. So it was awesome that we could offer her this option.
Especially after 3 surgeries, I'm sure she did not want to go back for a fourth. Um, Thank you. So, with that, I'll give you the summary and key takeaways. So, multiple biologics are available. We're thrilled about this. It gives our patients so many more options, and others are in development. The optimal sequence of surgery and biologics that still remains undefined, but biologics can be effective in patients with or without a prior surgery. Shared decision making is critical. Long term strategies may include tapering dosing intervals, as we mentioned in a couple of studies looking at that. And then multidisciplinary collaboration supports optimal patient outcomes and continuity of care. So, with that, thank you for joining us. And thank you to Dr. Franzese for your excellent insight into the discussion. Please visit peerview.com/back T2 in CRS with nasal polyps hyphen ARS to claim credit and access the activity materials. We hope you found this activity to be useful in your practice, and please check back for the on demand version of this series featuring both parts of the discussion.